I'm relatively new to the Aboriginal child and youth mental health team. I used to work at the Saanich Child and Youth Mental Health team before that. But when I was in Ontario, as well as in Quebec, I did work with Aboriginal communities. And the idea is taking a cultural perspective on treatment and understanding and respecting sort of the community and cultural sort of factors that impact. And as we know, some of these communities are at high risk for a lot of types of behaviors. So it's certainly opening my eyes to things that are going on for sure. So what I'd like to do today at this portion is to kind of go, now that we've looked at assessment, triaging, and treatment, kind of consolidate that information a little bit. Now that you've gathered that information with your clients, they've walked through the door, you've used Therapeutic Alliance, you've gathered information through clinical interview, you've sort of followed some basic assessment or possibly moved on to a complex assessment. Perhaps you've used the stress inventory or the OSI to kind of gather some information so that sort of guides what you do next. So the idea is informed practice. And as Dr. Nixon pointed out, there's a fair bit of research to sort of help you guide you as you sort of move into treatment decisions. But one thing I do know from my experience, and I'm curious from everyone else here, is that no two youth are the same who self-injure. So while they might have some common factors, there's so many other factors that come into play that we have to take into consideration as well. So some of them, as Dr. Nixon presented, are in the research. And part of that is sort of helping us determine what treatment modality we use, keeping those factors in mind. Okay. So a lot of this was already covered by Dr. Nixon, the idea that individual interventions are guided by a range of different factors, so age, cognitive developmental stages. I also work with younger kids, and it's very interesting. I'm encountering a lot of kids who are 8 and 9 and 10 on the reserves who are self-injuring. And so I have to adapt what I'm sort of presenting to them to an age level and developmental stage and a cultural perspective that respects where they're at. Motivation for change. How many of you guys have met kids who are like, I don't want to change, I don't want to do anything different, this is it, this is how I want to be. And then we go, what do we do, right? So that's something we'll talk about a little bit later, what sort of treatment modality you can use for those youth. Family involvement. We run the self-injury treatment group, and concurrently there's a parent group that runs with it. And I find that when parents are a part of it, it actually is far more effective. And using that systemic approach is very effective. Looking at acute and chronic stressors, involving a team. So I don't know how many of you sort of have a team-based system, so you can use the strengths of your team to help you triage the case. I apologize, I have a bit of a cold, so I'm going to drink some water while I go along. And as Dr. Nixon mentioned, it's really important to assess for Access 1 issues. So what we get when we do these trainings a lot is we'll just give us the formula of what we need to do when we have someone who self-injures. And there's no A to Z exact formula. Unfortunately, that would make life so much simpler, in part because you do have to take into account things like anxiety, depression, severity levels, ADHD. In the case that Dr. Nixon presented earlier, the idea of addictions. Is there suicidality concurrently happening? Eating disorders. A lot of the youth that we have in our group also have concurrent eating disorders. So the idea is you're not only just, the self-injury is perhaps a coping mechanism, but what are some of the underlying factors underneath that, and treating those as well. Okay, so I'm going to review these different individual treatments very briefly. Unfortunately, I don't have time to do the training on each of those. Those are individual workshops in and of themselves. I'm just going to give you a brief overview of them. There are some handouts that I printed out in the back that sort of give you websites and ways to gather more information about these different treatment modalities. But I'm just sort of highlighting some of the best practice treatment modalities that are out there for different issues. And again, the research does not yet conclusively tell us which mode of treatment is best for youth who self-injure. So what we do is guide ourselves based on other factors to choose which interventions are ideal. So how many of you guys provide psychoeducation to your families when they're, or youth when they come in for self-injury? And so a lot of what Dr. Nixon did for us earlier this morning was, in fact, gather up all the information so that you're abreast of all the different factors that may lead to someone using self-injury as a form of coping. So we often get parents who come in and say, why are they doing this? What's going on? And not just parents, youth will actually ask, I don't understand this. And that creates a sense of anxiety and fear within the family and the youth. So just giving them some basic information, honest, research-based, accurate information about what this is. It's often an important initial step in a lot of different forms of treatment. There's no specific psychoeducation program that's shown in the research that is the best way to approach this for self-injuring youth. There is a handout in the back that we kind of summarize that's from the chapter. So the book has various chapters in it, and there's lots of handouts and materials in the chapter itself that you can photocopy and present to parents when you're sort of meeting with them, or youth as well. So there's lots of materials in the chapter. So there is a handout in the back. So there's various goals of psychoeducation. And again, like I said, dispelling myths that anyone who's self-injuring must be suicidal, so they should be hospitalized right away, that only girls do it, that it's attention-seeking. So the idea that there are a lot of myths floating out there, and part of the psychoeducation is really giving them concrete, important information. So this is how we do the psychoeducation, or start that process in our group. So we make it very, very visual, and the idea it's, we call it the BS theory, the biosocial theory. And so we sort of use visuals to sort of target that biologically, some people, their bodies are different. So for some folks, a trigger might happen internally or externally, and they're very sensitive. Their body's going to be a rocket. It's going to get really agitated or upset, and it takes a long time for them to calm down. So the idea of helping them reflect on whether or not their body is vulnerable to emotions. And then we discuss both the internal and external environmental triggers. And that most people, and again, providing validation, when you're experiencing a lot of negative stressors or triggers, have to cope with it somehow. People who self-injure may cope with these types of ways. So behavioral problems, feeling confused, impulsive, emotional, unstable, have interpersonal problems, and self-injure as a way to cope. So we use the visual as a way to get them to understand the cognitive components, the stressors, the triggers, and also provide some sense of validation and a sense of how this is going about. So one therapy that's been looked at and briefly for self-injury is problem-solving therapy. And when I think of this, I realize that a lot of us do this concurrently in conjunction with other forms of therapy. So really, there's the theory that maladaptive coping is the reason why youth self-injure. And part of the therapy is really to break down, have them identify the problems, break it down, and make sense of it for them, and have them find their own solutions, setting goals incrementally and helping them formulate their solutions and see whether or not they're achieving their goals or not. How many of you folks kind of follow this type of model for treatment, or parts of your treatment? A few of you guys, yeah. And again, it's sort of a foundation of DBT as well as CBT also. So there's some sort of, lots of folks out there who are using PST as a format of treatment for self-injury.